So welcome everyone to this talk about entering Radiology ST3. I'm Louise, I'm one of the UKRST coordinators, and from UKRST team we also have Sadaf here, who's one of the leads from the UKRST team. And as for our speaker, Mohammed is going to give the talk today. He actually entered ST3, that's the same way, 3 years ago, and now in 10 days he's completing the training. So well done to him, but also congratulations to all of you who made it. So before we start, just a few housekeeping rules. First of all, please, if you could just keep your cameras and microphones off, unless one of us asks you to turn them on. If you have any questions, feel free to put them in the chat and we'll do our best to answer them at some point of the talk. And basically this meeting is going to be recorded. So if you're participating, just please be aware that we are recording the meeting for anyone who isn't able to make it today. So passing over to you, Mohammed.
Thank you, Louisa, for the introduction, and thanks, Sada, for organizing this. Welcome, everyone. Congratulations on your training offer. My name is Mohammed. I'm currently an ST5 trainee. As Louisa said, I joined this scheme when it was first advertised 3 years ago in 2022. Let's make this a two-way sort of learning, since there's just 4 of you. Do you guys wanna, if you wanna write down in the chat or wanna open your mics and let us know your name and where is your where are you going to start your training? Feel free to open your microphone, or if you don't wish to open your microphone, you can just type in the chat.
Hi, I'm Akash. I'm starting my ST3 at the Northwest, Mersey and West Lancashire.
Hi, Akash.
Hi, Mohammed.
Hi, I'm Ibrahim. I'm starting also in Northwest and in Mersey and West Lancashire.
Hi, Ibrahim. So Akash and Ibrahim are going to be my future colleagues, because I'm finishing training in the Northwest as well.
My pleasure.
My pleasure too.
Likewise, thank you. Anyone else want to share their where they're gonna start their training? Okay, hi Smita, East Midlands, good, congrats. Nesma, East London, Royal Free, very good, congrats. So I think we've got Hand Southwest, Severn, very good, congrats. It's just Dina left. Do you want to say where you're starting your training next? Okay, that's all right. Well,
Dina told me she would be late. She's starting in. Sorry, I couldn't forget.
That's all right. No problem. So today's talk is about training scheme. What's the training scheme made of? What is a portfolio, e-portfolio, and some other information about your start of training. It is a slightly long presentation, so we can have a break in the middle, and if you have any questions, just let us know at any point, because it's just 6 of you, so there's not much interruption. I'll try and answer as many questions as I can, and the benefit this year is hopefully most of you are gonna be starting, I think probably next week or in 2 weeks, so you will have this information fresh in your mind. So this is our agenda for today. This is some of the stuff that we're gonna discuss. I'm happy to discuss anything that's not mentioned already. If you have any extra questions, just let us know towards the end. So what are the responsible organization of you as a trainee? This is the structure, at least in the Northwest, and I think the Midlands as well. You as a trainee, first point of contact when you get your when you apply for training is usually Health Education England. And you have also the deanery. This organization is responsible for your education and training program. They are responsible for your recruitment process. And also if you need to apply for something called out of program, which means you take a career, a sort of career break to do something either academic or non-clinical, or if you want to apply for less than full-time, we're going to discuss what these things mean in a bit, or if you want to apply for a study leave for a conference or exam. Usually this is done through the deanery, and sometimes the Health Education England will be involved as well. You have the lead employer. Lead employer is an organization that provides you with employment services. They have the human resources team. So basically anything related to human resources, whether letter of proof of employment, payroll, anything related to your salary, and also occupational health. And then throughout your training, you'll be sent to host organizations. It depends from deanery to the other. For example, in the Northwest, usually you are sent to a host every 6 months. Every 6 months, you go to a new host. So the host organization is basically the hospital that gives you day-to-day supervision and management, and check your attendance, approve your expenses. For example, you have travel expenses, and provide you with your day-to-day work schedule and on-call schedule. This is the structure in, I think, the Northwest and the Midlands. It might be slightly different in some other deaneries, but you get the general idea. So moving to your timeline. So there is a timeline for training in the UK, which from ST, it used to be run through program from ST1 to ST5. You are joining at ST3, so all of you must have already completed FRCR1. Completing FRCR2A is a must by the end of your ST3. And completing your FRCR2B is something that needs to be done at some point between ST4 and ST5. After that, you will be granted a CCT, a Certificate of Completion of Training Program, and then it's up to you whether you apply for a consultant job or a fellowship, or it's up to you basically what you do after that. There is something in your curriculum called critical progression point, which means if you have not completed all of your curriculum milestones by the end of ST3, you will not progress to ST4. What happens next depends on the outcome of your yearly assessment. Most of the times you will get what we call a training extension. So if the problem is, for example, you have not completed the 2A exam, usually they give you a 6-month extension. So instead of finishing in 3 years' time, ST3, ST4, ST5, you will finish in 3 years and a half. So that's why you should plan ahead. You should plan your ST3 year, make sure you finish all your milestones, exams by the end of your yearly assessment. So this is a question that I used to get a lot. What is a CCT and what's a CSER CP? So this information basically is outdated. Let me go back to the slide. Since I am one of the first trainees who've joined the training scheme, we have received a formal recommendation from the RCR to gain a CCT, not a CSER CP. So the outcome of your training by joining the ST3 is going to be CCT and not CSER CP. And CCT, it does not matter in the UK. Basically, the last 2 lines does not matter in the UK, but in the EU and other countries, CCT is well recognized, while many countries are not yet recognizing CSER CP, at least not at the same level as CCT. There's another way to look at your training. First 3 years they used to be called core radiology training, but basically they're now called clinical radiology training. The aim is to train you into general radiology. So for example, if you start your ST3 year and you can see your schedule is heavily GI loaded, that's not something, unless you want this, you can always request it to change, because you're supposed to be covering general radiology, not subspecialty. So it's a good opportunity to build your general radiology knowledge in ST3, and then after that you would get the chance to choose a subspecialty. and choose a subspecialty for ST4 and ST5. And technically, you're supposed to maintain your general skills while you are working on your subspecialty training. There's one thing to add here, that if you choose IR, interventional radiology, or neuro IR, there will be an ST6 year added. So whoever goes into the interventional pathway, they will need to do an additional year, ST6 year. Subspecialty training. So the application process is variable. It depends upon the delivery, but you have to get ready. Usually the IR, interventional radiology, and neuro, as well as with a neuro diagnostic or neuro interventional radiology, they have separate process. In Northwest, you have to apply through a form, application form, and send your CV to the TPD and head of school with a cover letter, why you want to do IR, why do you want to do neuro. And later on, the applicants are shortlisted for interviews. You have to do an interview, and based on your CV, you will either be selected or not. And if you are selected, you will be allocated to a region, again, according to your rank. So what does this mean? It means that you have, I think in the Northwest, the applications will open usually in November or December this year, at like the beginning of your ST3 year. So you have 3 to 4 months to try and build your CV towards a certain subspec. If you are interested in IR or neuro, I advise you to start right away building your CV towards this, either by doing audits. Of course, there's little time to do research in 3-4 months, but whatever you can do to show your interest, attending conferences, for example. That's another good thing. What if your deanery is not taking up IR trainees or neuro trainees this year? Or for example, if you applied and you didn't get a position. Sometimes there are other deaneries that can accept trainee applications from other regions. And for example, if you are a Northwest trainee, you couldn't get an IR, and then you can apply for IR position at a different deanery through Oriel. And it becomes, you already have a national training number. You're not applying for training from scratch. You already have a national training number. Basically, you are just transferring to another deanery to start your subspec. This usually happens for IR and neuro. Apart from that, most of the other subspecialties are less competitive, except maybe breast and peds. Usually there is no specific application process for this. Usually you just fill in a form and send it to your TPD or head of school. But again, it depends on the deanery. But most of the time you will get your desired subspecialty. So you should, if you have a certain subspecialty in your mind, you should check the application process. You can ask either previous trainees or senior trainees in your deanery, or you can just ask the TPD, basically. Salary, I think this is, again, I'm not sure if this is the new salary or the outdated. I think this number is for 2024. Basically, the correct number is going to be on the BMA website, the ST3 to ST5 salary. There is no pay protection, which means if you are already working in the UK in another position, let's say, for example, a specialist registrar or even a consultant, there's no pay protection. You will be placed on the national scale. The on-call supplement depends on the number of on-calls and frequency. For example, in the Northwest, we have something called the on-call hub. So we do lots of on-calls, and this number is usually supplemented and goes up to, I think, 80,000 with the on-calls. Locums, you are allowed to do locums in your own time. If you do internal locums in your deanery, it's fine. If you do external locums outside of your deanery, these should be declared to the deanery, and you should also inform your ES. We're gonna discuss in a bit what is an ARCP and what is Form R. So Form R is basically, it used to be a paper form. It's now an electronic form. Basically, it's a form that you need to fill annually. to update in year if there are any changes. It's made of two parts. First part is your personal and contact information for the deanery database. So if this changes, for example, you move houses, you need to update part A of the form. And part B, which is the important part, it basically discusses your scope of practice. Are you still in training? Are you still full-time training or less than full-time? Have you taken a career break? Are you doing any locums? These are the sort of information that should be included in your part B form. This information would inform the ARCP panel whether you are fit to practice or not. And then they send this information to the GMC and they use this information for your revalidation. For those of you who don't know, if you have a GMC license to practice, you need to do a yearly appraisal, and then every 5 years you'll be revalidated. Revalidation means that they assess whether you're still fit to practice and you're still fit to hold your license to practice medicine. So basically, the information is in part B is used in this assessment. Any questions so far? All right, we'll move on. No, it's lots of information to take, but it's a good time to learn these stuff before you just start. So your supervisors, when you start, there are different positions. When I started, I was confused. What's the difference between each one? So let's discuss what sort of supervisor you'll have and what their role. So you probably have communicated with your TPD already, training program director. So a TPD is responsible for leading and coordinating your training. They will assist in your appointment, training, and updating your educational supervisor. So usually your TPD will assign an educational supervisor for you. They also responsible to monitor and inspect training placements. So if you have any comments or feedback about your training placement, you should contact your TPD. And they will also allocate you to placements. So your training is done in rotations in most deaneries. So your TPD will assign you each rotation. In the Northwest, for example, we have a rotation every 6 months. And they also will approve your study leave. If you apply for less than full-time, they will either approve it. Usually they approve it, but if they have any questions, they will discuss it with you. And also if you need to apply for time out of training, this is done through your TPD. Okay, so what's an educational supervisor? So the educational supervisor is a trainer who's responsible for the supervision of your training. And they are your first point of contact outside of your placement. So if you have any issues and you don't want to discuss it with the consultants or supervisors in your current hospital, your first point of contact should be your ES. You will have one ES throughout your training. So they will choose an ES for you, and this ES usually does not change throughout your training. And you have to have at least 2 to 3 formal meetings per year. So formal means meetings should be documented in your portfolio. And at the end of each year, your ES will write down a report about your performance throughout the year. And this report is very, very important for your annual appraisal or annual assessment. And based on this report, the panel will either give you a satisfactory outcome, meaning you will progress to the next stage or not. You might have heard about this, TSTL, Trust Specialty Training Lead, and some other areas they are called college tutor. So basically each radiology department has a TSTL. A TSTL job is they lead the educational activities, they coordinate between the deanery and the hospital. They're usually responsible for your day-to-day work schedule. They will also assign an SCS for you. Sometimes they are known as a college tutor. So TSTL is a sort of supervisor. They're not directly supervising you, but they are responsible for your day-to-day work schedule. And they are the link between the department and the deanery. So in each radiology department, there is a TSTL. Clinical supervisor. So think of a clinical supervisor as an ES, but they are just for this single rotation. So they are going to be a sort of your ES, but for a specific rotation. That's it. They are, again, responsible for overseeing a specified trainee's clinical work, providing constructive feedback during your placement. You will have one CS each rotation. So if you go to a different hospital, you will be assigned another CS, and also the other hospital will have their own TSTL. You should have at least 2 formal meetings per rotation. And this is basically the structure. So you have the deanery, you have the head of school. Most of the times you don't need to contact the head of school unless there is a huge issue. You have the TPD, and then you have your ES. And then when you go to a rotation, each rotation will have a TSTL and a clinical supervisor CS. And then you go to another rotation, another TSTL and another CS. So as you can see, your ES, TPD, and head of school usually do not change. And some deaneries like the Northwest, there is a TPD for each stage of training. But apart from that, your ES and TPD usually do not change. So job rota and work schedule. Hospitals are required to send you the rota 12 weeks before the start of rotation. This usually does not happen. But anyway, I hope by now, because most of you are starting in 2 weeks, you must have received your work schedule, which means your day-to-day rota. If you have not, then you need to contact your TSTL or someone in the department to send you the rota as soon as possible. So how is this rota done? The rota should meet your educational needs and subspecialty preferences. What this means is that if, for example, if you are doing general radiology, the rota should meet your needs. What if you have specific needs? For example, I have specific needs with ultrasound. I can always talk to the TSTL and ask them to give me an extra ultrasound session, for example. So the rota can be changed. It's not the end of the day if the rota is not meeting your needs. You just have to discuss it with your TSTL. So you should have received already your work schedule, which means your day-to-day rota, on-call rota, if you're doing any. You should have received your TSTL details and CS details, and also the induction details. Okay, so feel free to post comments in the chat if you want. So we are following I think that's the up-to-date 2023 May curriculum. There are some descriptors. These are used in your portfolio. So whenever you do, for example, a procedure, someone will assess this procedure and give you one of these descriptors, level 1 to 4. In your stage, there is nothing that's going to be done as observe only. So level 1 in your stage at ST3 is not going to be used. For some procedures in your stage or some reports, you might need to obtain at least level 2, which means you are interested to act with direct supervision. Level 3 means indirect supervision, and level 4 means unsupervised. So whenever you aim to do a procedure or a reporting session, for example, and you're gonna get an assessment, you will be given one of these 4 levels. And then you have this in your curriculum. This is the required level for ST3. And this is basically what is used to assess you at the end of the year. So for example, image guided biopsy, you need to do level 2. Level 2 means under direct supervision. What type of biopsy? It doesn't matter. Lung biopsy, thyroid biopsy, breast biopsy, it doesn't really matter as long as you do a biopsy and you get at least level 2. The same for drainage, basic image guided drainage, for example, ascitic drainage. This one is a little bit tough, but you can do it in the IR with the IR team. Contrast and studies of lines and tubes, things like, for example, nephrostograms. Again, most of the departments have an IR team, and they will be able to help you with these IR ones. conscious studies of GI and GU, usually barium studies. This is a generic one, which means you can protocol and prioritize imaging referrals, report plain films, ultrasound, CT, and MRI. Most of the reporting, you are required to be at level 3 by the end of ST3. So you need this level by the end of the year, not at the start. So what this means is that, let's say you have done a CT session with a consultant at the beginning of the year, and they have given you level 2, but you need level 3. That's fine. As long as you slowly progress throughout the year and do another one and get level 3, it should be fine. It's always also useful to discuss with the consultant before the SSU, what level do they have in mind, and what you can also ask them if they think, for example, you are at level 2 and you need level 3, you can make a plan with them. What do you guys think that I should do for me to get a level 3? So remember this page in your curriculum. It's on the RCR curriculum. When I started, I had this page with me on my phone because this is what basically you need toward the end of the year to progress to the next stage. And as you can see, if RCR2A exam is a must, you must clear this by the end of ST3. Any questions so far? Okay. These are some other generic things that you need to do. Have a read about it. Basically, it's something about your work ethics and acting as a teacher, a leader, and safeguarding, things like that. You don't need to get, you don't need a consultant to assist you against these, but at the end of the year, your ES, your educational supervisor, will assist you and give you a mark. Most of the times, if your other milestones are satisfactory and your colleague feedback is also satisfactory, your ES is happy to complete this for you. Again, this is in your RCR curriculum page, which is this document on the RCR website. Okay. I think I prepared this QR code last year. Hopefully still works. So this is the RCR curriculum website. If you Google it, it will be first on the top of the page. Okay. So there is something called WPBA, workplace-based assessments. These are the tools that are used to assess you throughout the year. And these are basically tools on your portfolio. There are different types of tools based on something that's being assessed. For example, there are tools for ultrasound, CT, or teaching. You need a minimum number of assessments per year, which is 12 assessments. You also need to achieve a minimum level for each assessment. As we discussed earlier, level 2, 3, 4, according to the competency that's being assessed. As I said earlier, before being assessed, you should agree with your assessor on this in advance. So these are the different assessment tools on your portfolio. Once you start, you will have access to the Kaizen, or it's not nowadays, it's called RISR, and inside, which is basically your e-portfolio. Inside your portfolio, you will have access to these tools. We're going to discuss each one in details, but basically MSF is feedback about you from your colleagues. It's usually anonymous. Mini IPX is an assessment tool for reporting, X-ray reporting, MRI, CT reporting. RadDops is a tool to assess your procedure skills. For example, drains, biopsies, or ultrasound. Ultrasound is considered as a procedure. Teaching observation is to assess your teaching skills. MDT to assess your MDT skills, and the QIPAT to assess your audit skills. Let's start with the first one, multi-source feedback. So basically, you need a minimum of 12 people to give you feedback throughout the year. So once you start, you open an MSF ticket and start sending it to your colleague ask them to provide you for feedback. Usually you need a mix of people. So for example, 2 to 4 senior doctors, 2 to 4 doctors in training, radiographers, nurses, and other team members. So try and have a mix, and yeah, so that's something that is mandatory for your annual assessment. So basically, that's the form that they get. Anyone who assists you will get this form. They will basically, it's just generic questions about your communication skills with the patients or healthcare professionals, your attitude to patients and staff, your team player skills, reliability, and leadership skills. So basically, they will give you a grade from 1 to 5. Either you are excellent or you don't meet this certain criteria. And this feedback will go to your ES, educational supervisor, and will be used for your yearly assessment. Second tool is Mini IPX. Stands for Many Imaging Interpretation Exercise, and this is to assess radiology reporting. You need a minimum, so overall you need 12 assessments per year. Basically, you need 6 of them to be Mini IPX, and ideally 2 per rotation. And this is how the form looks like. Basically, you fill in the details, your specialty, clinical radiology, what modality, CT or MRI or X-ray, etc. What system, GI, GU, etc. And then case description. What sort of cases have you reported? What sort of setting? For example, was it A&E setting, cold reporting, etc. And you add some comments about your own performance. And then you send the ticket to your assessor. Usually the assessor is a consultant or a senior trainee, and they will also have additional boxes to write their feedback and give you a level. And this is the assessor's point of view. So they will write down their name, role, difficulty of cases, what have you done well, what other areas suggested for improvement, agreed action plan, and then most importantly, they're gonna give you a level, entrustment level. And this level will go into your portfolio, will be recorded. And then if you have achieved the required level, then it's good. If you've not achieved the required level, then you should aim to do this assessment at some other point after, of course, improving your clinical performance, and then get the required level. Third tool is RadDops. Again, it's very similar to many IPX, but this one is just for procedures. Basically, it's the same exact thing. Someone assess your practical procedure, consultant, a senior doctor, or someone who is qualified to do this procedure. It doesn't have to be a consultant, basically. You need, again, a minimum of 6 per year. And keep in mind this, that you need the required level for each RadDops or mini IPX based on this curriculum. Teaching observation, you need to do 2 formal teaching observations per year. Basically, this is an assessment done to evaluate your teaching abilities. You need 2 per year. You should aim to collect feedback from your attendees. So if you provide a teaching session for medical students, try and obtain feedback, and you can upload your feedback.
Sorry, Mohammed, to interrupt you. We can't hear you. Mohammed, we can't hear you.
Please give me a shout if you can hear me.
Yeah, we can hear you now.
Okay, thank you. So which last bit did you hear? Was it teaching observation or?
Yeah,
Yes,
just at the
entire-
end of the teaching observation, yeah.
Okay. So I was saying there are plenty of opportunities to teach throughout the year. And then I started talking about MDT assessment. Basically, it's something that you don't need to stress about it. It's not required for ST3, but it's something just to know about. It is a ticket to assess your ability to do MDTs. It's not required for ST3. It's required for ST4 or above. You need 2 per year for ST4 and ST5. If you want to do it as an ST3, excellent. If you don't want to do it and you want to focus on other things, that's fine. Quality improvement project and audit assessment. So you are required to do an audit, 1 audit per year. And this tool is a tool that will assess your audit capabilities. Again, you need to do 1 per year. You attach your audit certificate and summary of conclusion or recommendations to the ticket and send it to the supervising consultant. Okay, so what other information is on your portfolio? Usually there is a supervisor review. You should, as we said earlier, you should meet with your educational supervisor 2 to 3 times per year. First meeting, you usually discuss the plans of the year and also discuss the review points, which means when is our next meeting, basically. Your ES review, which is basically the formal meeting written on your portfolio. Usually you need 3. One is the induction meeting, the other is the mid-year review, and then the end of year appraisal and ES report. And this is very, very important. This is basically what is used to assess you at the end of the year, your ES report. If you have a satisfactory ES report and you have completed your milestones, then usually you will just progress to the next stage. As you said, for each rotation, you will have a clinical supervisor. You should arrange a meeting with your clinical supervisor to address your training needs. And you need at least 2 meetings with your CS at the beginning of the rotation and at the end of the rotation. If you are in a rotation more than 6 months, for example, a rotation of 1 year, then might try and do a CS mid-year meeting as well with your CS. So instead of 2 meetings, you'll do 3 meetings. In your portfolio, there is something called PDB, Professional Development Plan. Basically, at the beginning of every year, you should plan your year ahead. What I want to, what are the stuff that I need to work on for this year, and you add it to your portfolio after discussing it with your ES and CS. Your plan should include what are your reporting goals for this year. For example, I can write down that I want to be able to report MRCPs by the end of this year. What are your plan for procedures and interventions, audits, teaching, MDT, and research? But again, keep it reasonable. Don't write down things that are difficult to achieve otherwise, because at the end of the year, your ES and CS will assess whether you have completed this plan or not. So keep your plan as reasonable as possible. So this, I think this is from the previous. This has been updated. Basically, the portfolio has changed a little bit. But basically, previously you had categories in your plan that you can fill. Now you just create these categories manually. So you create a category and write down under each category what's your plan for this category. That's basically how I used to fill my PDB. For example, clinical skills. My objective is, for example, to be able to report or perform procedures at the level of ST3 by the end of the year. How am I going to address it? I will attend the reporting sessions. I will attend procedural sessions and IR. What evidence I will provide? I will provide assessment evidence from my consultants, which are many IPEX and RadDops. And what's the expected date to complete? Usually the expected date is at the end of the year. Right, before moving to this slide, because I know we've discussed so many things. First of all, anyone have a question? Happy to take questions at this stage. And secondly, do you want to have a break for a few minutes or you want to carry on? Feel free to type on the chat.
Hi, Mohammed. Can you please tell me if the mini IPX needs to be done 2 per 6 months, or was it 4? 2 per
So actually, your question is going to be answered here, because what I meant by that slide, you need 6 per year. But what happens is some trainees don't plan their year ahead and they leave themselves without doing any mini IPXs or any portfolio tickets, and they try to do everything in the last 2 to 3 years, 2 to 3 months. And this does not look good. That's why I said you should aim to do at least 2 per rotation and do the other 4 in the other rotation. So what I mean is, when the panels look at your portfolio, they can tell that you have done everything in your portfolio in the last 2 to 3 months, and this does not look good. It means that you were doing nothing throughout the year. So basically, try and space out everything you do in your portfolio. Do a couple of things in September, a couple of things in October, a couple of things in November. So it shows that you are continuously training and learning. Basically, that's what I meant by that slide. But essentially, you just need 6 per year.
Okay, thank you.
That's right. Any other questions? Do you guys want to take a break, or do you want to carry on? I think probably we're halfway. Yeah, we're halfway through, more than halfway through the presentation. So if you want to take a break, let me know. If I get no answers, it means you're happy to carry on. Okay, let's carry on. So I made this slide to show you how to plan for your year, basically. So in terms of assessments, if you need 6 assessments for IPX, if you do it this way, 2 at the beginning of the year and then 4 at the end of the year, that does not look good on your portfolio. Even though you have done the required numbers, which is 6, but your ES or your TVD might ask you, where were you during these 5 months or 6 months? Basically, there's nothing on your portfolio. You might have been working hard and doing everything by the book, but if it's not showing on your portfolio, then there's no evidence. So ideally, you would want to space out these assessments. So each one of these arrows is an assessment. Try and do an assessment every month or every couple of months, just to show that you've been continuously training. So this is your current portfolio. It used to be called Kaizen. Now it's called RISR. I'm not sure if you all have access to this by now, but if not, then by the start of your training, you should email the Royal College and ask them to send you login details for your Kaizen or RISR. This is a screenshot from my portfolio. Basically, these are the different types of tickets that you can create on your portfolio. Usually, you don't need the segment unless you're applying for CCT or time out of program, something like that. You will be using these 2 segments a lot. So at the start of your training, you go on your portfolio and assign an educational supervisor. So once you get your educational supervisor details, you write it down here in this ticket. And then once you get your rotation details, which means what hospital and what's the location of the hospital and what's the name of your CS, I don't know if you can see my arrow. But basically, you write it down in the assigned training post, OOPA or period of leave. And then this PDB goals is for your PDB. The assessment and evidence section is basically the 7 tools that we've discussed: May, IPX, RadDops, MSF, etc. These are the ones that you will be using a lot. Yeah, so I zoomed in. I didn't know that I've zoomed in on this. So supervision, first one you use to assign your educational supervisors. Once you write down your educational supervisor here, they will have access to your portfolio. Second one is you use to assign your CS and the name of your hospital. Yeah, I don't think we'll be using the other 2. This one is for your educational supervisor meeting. Usually, most of the ESs are able to create it themselves, but if they can't, you can start from here and send it to your supervisor to complete. And do you have a question? Can see your hands raised.
Yes. Actually, I was trying to assign my educational and clinical supervisor. I had their names and they asked me to assign them, but I was trying to when you start writing the name, they give you a list of names.
Yes. Yes.
But I couldn't find them, so I don't know what to do. Do I have to email them or what do I?
So the first question is: does your have your educational supervisor had trainees before? If it's the
I
first
don't know.
time they
I
have,
didn't contact the educational. The clinical supervisor was the one who contacted me because he is a clinical lead, and he
okay,
asked me if I have access to the portfolio, and I told him yes, and he told me that my educational supervisor is this person, and this is me. I'm your clinical supervisor, and you need to assign us on your portfolio. But
yeah. So if you type on their name and they're not coming up on your portfolio, this usually means that they are either a new consultant or they don't have access to Kaizen. It's a simple fix. You just need to email the RCR and copy in your supervisor email and tell them, this is my educational or clinical supervisor. I'm trying to add them, but I can't find them on Kaizen. And they will create an account for them, basically.
okay.
Does this answer your question?
Yes. Yeah.
Yeah, okay. So these two highlighted parts of your portfolio are going to be used for your ES and CS meeting reports. I was saying that most ES and CSs are able to create the reports themselves. Some ESs and CSs they don't know how to use the portfolio very well. So you can start by creating a preliminary report and just send it to your ES or CS so that they can complete the rest of it, basically. Okay, so we've heard about the ARCP. I've mentioned ARCP many times. Does anyone know what ARCP is? Anyone want to write down in the comments? So I've put a picture that is probably relevant to what ARCP means. So ARCP means Annual Review of Competency Progression. Basically, it is the annual review of your training year. It's a formal review by a panel of consultants at the end of each training year, usually done on late June. There is a reason I've put this in red. I'll mention it in a bit. You are not required to attend. It's done just the consultants. They will check your portfolio and your ES report. They will look at all aspects of your portfolio and give you an outcome. If your evidence suggests unsatisfactory progression, you will be awarded an outcome stating the action and time scale to correct the deficiency. The reason I put this in red is you're starting training, for example, in August. You might think that you have 12 months to work on your portfolio, but because the ARCP is done in June, it means technically you have less than 10 months, probably 9 months and a half to work on your portfolio. So keep that in mind when you plan ahead for your year. If they tell you your ARCP is in late June, it means that you should have completed everything by the beginning of June, basically. Okay, so we've mentioned that you will be given an outcome. The outcomes actually have numbers. You want to be giving outcome 1, which means satisfactory progress. You get to progress to the next year, which in your case is ST4. Sometimes you get a outcome 2. It means that some areas of your portfolio needed some attention, but you don't need any extra training time. You just have that in mind for the next year. Outcome 3 means you will be giving extra training time, and there's some other outcomes. You can have a read about it. For example, outcome 6 is you will be granted outcome 6 by the end of the training. which means you have completed your training. So this, if you Google ARCP outcomes, you'll be able to read a little bit about these. Okay, so this is an example of an email sent by my deanery. It gives me the date of my ARCP. In my case, it was 28th of June. And it says that I'm not required to attend and I need to have the evidence on my portfolio, all evidence on my portfolio 1 week before this date. Each deanery has an ARCP checklist, which means what things are required to be uploaded on your portfolio before your ARCP. Remember that you might have done excellent things throughout the year, but if you don't have evidence of these things, then no one can really tell if you've done these brilliant things or not. So try and keep evidence of everything. For example, you presented in a conference, try and get a certificate and upload it into your portfolio. So what are the things required for your ARCP? We've mentioned the workplace-based assessments, IPXs, DOPSs, etc. And you need the specific number and the specific levels we've mentioned. You need at least 2 to 3 ES reports, beginning of year, mid-year, and end of year. You need to upload your Form R. We've mentioned Form R in the beginning, parts A and B. In our deanery, it is mandatory to complete these surveys and upload an evidence that we have completed these surveys. So if you ever get an email about a survey, particularly from the GMC or Health Education England, please pay attention to it because it is very easy to miss the deadline and forget to complete the survey. In most deaneries, these are mandatory surveys. You have to complete it and provide an evidence that you've completed. That evidence is like, for example, the confirmation email that you've completed the survey. Logbook, again, this is not in all deaneries. In our deanery, there is a logbook, which means the number of reports and procedures that we've done. You don't need to write it down every month or so. You can, in most cases, you can just get this from your PAC system by the end of the year. You need to have your PDB on your portfolio. We've discussed what a PDB is, and usually you should have already created a PDB at the beginning of the year. If you have been attending teaching as part of your training, then you should upload the evidence of this on your portfolio. Many deaneries will require annual leave evidence. In some deaneries, this is electronic. You just go to a website called ESR and just download the evidence of your annual leave. In some other places, it's paper form. Basically, how many annual leaves have you taken this year? Annual leaves, sick leave, and study leave. If for example, for ST3, it's mandatory that you have completed your FRCR2A, then you need to upload the FRCR2A certificate. And any other achievements or certificates for the year, feel free to upload them as well. This is an example of annual leave evidence record from the Northwest Deanery. I think this form has changed, but basically you get the idea. You write down the dates you've taken annual leave, study leave, and sick leave, and then your TSTL or CS can sign them, and that's it. This is an example of lookbook. Again, this is for the Northwest Deanery. Basically, how many plain films in each placement, how many CTs, MRs, etc. Then we move on to the study leave. So, at least in the Northwest, I think most trainees have 30 days per year. You're allowed to take study leave up to 30 days per year. Study budget, which means the budget that covers your expenses. This is highly variable. In the Northwest, it is £500 for ST3 and 4 and 5, I think. Application types, you can apply for time only, which means I just need time off. I don't want you to cover any expenses, or you can apply for time and expenses. There is a process for study leave. It is variable from deanery to the other, but basically, for example, let's say I'm applying for a conference. I need to have discussed this with my ES and CS, and they are happy for me to apply. and then I apply through a certain system or website, and admin team will check my application. They send it to the TPD for approval, goes back to the admin team, and then you get the approval email. Approval is at the discretion of the TPD. So basically TPD, it's up to the TPD to approve or not. You need to apply at least 6 weeks in advance. So if the conference is next week, usually it's too late to apply for study leave. And expenses need to be pre-approved. So if you think you will pay, for example, train tickets, accommodation, etc., you have to write down all the expected expenses in your application. And you have to claim the expenses within 3 months from attending the course or event. For RCR exams, if you want to study for the RCR exam, check your local policy. For the Northwest, you're only given study days for the 2A exam. You're allowed to take up to 7 days before the 2A exam. No study leave for part 1 or part 2B. You have to do annual leave instead. And also the study budget does not cover the cost of the actual exam. It covers the cost of courses and conferences. Annual leave, again, because some of you is new to the NHS, your annual leave balance depends on how many years have you been working in the NHS. If it's less than 5 years, you have 27 days per year. 5 to 10 years, 29, more than 10 years, 33 days. In some other places, if it's more than 5 years, you just get 33 days. Who do you request the annual leave from? Usually it is requested from your host placement. So you don't need to email your TPD or ES about annual leave. You just email your TSTL in your hospital, and sometimes it's just the secretaries or admin team, and tell them that you want annual leave. Usually, again, you need 6 weeks notice to request annual leave. But I find it in radiology, there is a leeway because most of the times, most of the hospitals or supervisors are supportive. If you have something that you need to attend and it's just next week, you can always discuss with your TSTL, and most of the times they're happy to approve it. However, if you have on-calls during your annual leave time, it's your responsibility to swap on-call shifts. Unless, of course, most of the time, even if you applied like 3, 4, 5 months earlier, most of the time you still have to swap your annual leave. Many hospitals will try to accommodate your annual leave and avoid putting you on calls, but if you end up doing on calls during your annual leave, then try and swap them with your colleagues. Clinical duties as an ST3, this is what is expected from you. You're expected to be able to report plain films and acute CT reporting. However, this will need to be signed off by a consultant. Some deaneries allow ST3 trainees to sign off plain films independently. I think that's the case in West Midlands. Ultrasound and MRI reporting is done under direct or indirect supervision, again, depending on your clinical skills. You are expected to cover on calls at this stage independently. Consultant is available, but off-site. You can always ring them if you need help. The on-call commitment is usually acute CT, plain films, and sometimes ultrasound. Usually, we're not doing ultrasounds out of hours, but again, depends. If you're doing a rotation in a pediatric hospital, you might need to do ultrasound out of hours. Some rotations do not have any on-calls, which means you are just doing a 9 to 5 job every day, and you will be paid the basic salary. Just remember that all your reports for on-calls are going to be checked at least next day by a consultant. So you are always covered from that point of view. But you are responsible for your report. Your reports are very, very important. For example, if you say this case is appendicitis, the surgeons will take the case to the theater and operate. And that's why I advise you 2 things. First of all, if you feel that you need some time to shadow, feel free to discuss with your on-call rota manager that you need shadowing for 1 month or so. Secondly, I advise all of you to have indemnity, professional indemnity, which means indemnity coverage in case of error or mistake. This is an honest advice to everyone. Does this mean that on-calls are stressful? I don't think they are stressful. I think most of you are more than capable to handle on-calls, but just in case, indemnity in your stage is very, very cheap. It's just going to be around £100 per year or something like that. Okay, what's less than full-time? Some of you might want to work less than full-time, which means they don't want to work full-time 5 days a week. You need to provide 16-week notice before applying for less than full-time. There used to be specific eligibility criteria. Now this is old. Everyone can apply for less. Anyone can apply for less than full-time, basically. So I'm just gonna skip this because this is old information. Anyone can apply than less than full-time, but there are usually 2 windows per year to apply for less than full-time. I think it's mid-March to mid-April if you are starting in August. So some of you are on visa sponsored by Health Education England. These numbers are from last year, I think, because there are certain visa requirements, certain salary requirement for your visa. There is a minimum of hours that you need to work to gain that minimum salary for your visa to be valid. For you at an ST3, you can work down to 41%. So if you, again, the exact numbers are going to be with Health Education England, but this schedule was sent to us by, this table was sent to us by Health Education England last year. Hopefully these numbers are still the same. 41% was the minimum that you can do if you want to still be sponsored by Health Education England. Yeah, I think the salary went up. It's 55,000 per year, so you can even probably do less than 41%. Most trainees do 80% if you want to go for less than full time, which means you're gonna work 4 days a week. Okay, I'm just gonna quickly mention something called Radiology Academy. Some deaneries have what is called Radiology Academy, which means a non-hospital placement that you go and have some lectures and discussion with consultants. This is the Radiology Academy in Leeds. There are many reasons why they have established Radiology Academy. First of all, they have more trainees than ever, and sometimes hospital rotations are not enough for all trainees. And also, it gives you a little bit of extra theoretical knowledge or knowledge related to exams. Now, most of the dinners usually started with ST1. Most of the dinners have expanded the academy program, and they are now including ST2 and ST3. They will also give you teaching for FRCR exams, and your teaching time is protected. You should send your teaching schedule to the TSTL to release you from your clinical duties. And remember, if you are attending formal teaching, keep record of your attendance and submit it to your ARCP. You can just create a sheet, dates and topics of teaching, and that's it. So I think we're approaching towards the end of our presentation. Remember, it's very, very important to plan your year, set up your Kaizen portfolio, add your ES and CS to your portfolio, add the name of your hospital and the duration of your rotation, add your TDB when you start, request an induction meeting. So if you already have your ES and CS details, email them, introduce yourself and request an induction meeting with them, formal induction meeting. And the induction meeting can be done either face-to-face or online. Start your training and address your educational needs. So all of us have different backgrounds, educational and clinical backgrounds. So if you feel, for example, that you need extra training in ultrasound, have a discussion with your supervisors and try and get as many ultrasound sessions as possible. Collect evidence for your training. As we said, certificates, RADDOPS, mini IPXs, etc. And the evidence should be spaced as possible. Aim to get the required level by the relevant workplace-based assessment. As we shown earlier, the page from the RCR curriculum, you aim to get these levels by the end of the year. So we have it here. So basically I think this page is very, very important. Try and print it out and have it in your office or on your phone. I also, when I started, I sent this page to my ES and CS so that they are aware that I need these levels by the end of the year. Do you guys have any questions about this particular page? Because I think this is the most important one in this presentation. I'm just looking at the chat, see if you have any questions or feel free.
I have one question. The third point says image-guided vascular access and basic catheter wire manipulation. But during a 6 months of posting, or maybe a year of first year of ST3, we may not be posted in IR, or we may not have an opportunity to have vascular access or wire manipulations. So how do we get the two competency for that?
So that's a very, very good question. So it starts with, you have 2 rotations at least. Hopefully one of them will have an IR department in one of them. If you have an IR department, then you should try and go at least 4 hours each week and do IR stuff. And you just need level 2. Level 2 basically is the least level you can get, which means you have done something under direct observation. Even if you've not done it in a correct manner, there's someone directly observing you. But let's say in an extreme situation, there is no IR department in my rotation. Then you should not leave yourself to the end of the year. You should, again, as we said, plan ahead. Have a discussion with your ES and CS. Sometimes they might suggest that you go 1 day a week in another hospital, neighboring hospital, in a sort of informal arrangement. And this has been done many, many times. For example, in my ST5 years, I used to go to a tertiary center informally 1 day a week. So these things can be done, but you just need approval from both hospitals, basically. So that's important that you have this in mind once you start. If you think your placement does not have biopsies or drainages, or for example, catheter wire manipulation, you have to discuss it with your supervisors. If you leave it to the end of the year and then said, okay, I didn't have the chance to do these, then your supervisors will tell you why you didn't discuss this at the beginning of the year. We could have done something for you. So I think these are usually the solutions you have. Either try and do it in your hospital, or they might send you to another hospital informally 1 day a week to do these kind of procedures. But in my experience, most of the hospitals have even a small IR department that would be able to accommodate you.
Okay, thank you.
No problem. Any other questions?
Yes, I have a question.
Go Ibrahim.
Is there a number of procedures in each, for example, in case of image-guided vascular access, this should be a certain time, a certain number of procedures, or just the consultant is happy to say that I have performed this procedure?
So for your portfolio, you just need 1. But now the tricky part is the consultant. So if I go to a consultant, it's the first time ever they see me, and I tell them I want to do a drainage, and I want level, for example, let's say level 3 or 4. Most of the times, 19% of the times, they're not going to give me level 3 or 4 because that's the first time they see me ever. So what you can do is you can attend with that particular consultant a couple of times and do a couple of drains, and then tell them, okay, can I do the next one? Now you know my level. Can I do the next one, and can I get level 2 for it? In that case, they will be able to give you the level you need.
Just once.
For your portfolio, you just need it once.
Okay.
But you need a total of 6 DOPs, 6 procedures, regardless of the type of procedures. So you can do 2 biopsies, 2 drainages, 2 ultrasounds, and that's it. You have done 6 procedures. So yeah.
Got it. Thank you.
Okay, no problem. Any other questions about this page? Okay, we'll move on. So again, part of planning our year is that we need an audit per year. I find it difficult if you leave the audit towards the end of the year. Usually, for me personally, from January to starting from January and February, it starts to become a little bit stressful because your ARCP is in 4 months and you need to get everything done and ready for your ARCP. So I advise you to start on your audit as early as possible, because usually you have so many sample audits that you can do. There is a library of audits. I forgot the name. It's on the RCR website. I think it's called Audit Live, something like that. They have a library of audits, examples of audits, thousands of audits that you can try and do in your department. If you don't have, if it's your first audit, basically, then I advise you to choose something simple. It will give you a good experience. And yeah, for each audit, you need a supervising consultant, basically. Remember to do an end of rotation meeting with your CS, mid-year meeting with your ES, and then next rotation, repeat. End year, and then end of year meeting with your ES, and submit your ERCP documents at the end of the year. Yeah, if you didn't require logbook numbers, you might want to update your logbook every few months and obtain evidence of your annual leave records. And this is basically a map that I created to help you understand what I'm saying. So this is a map based on 2 rotations per year. As I said, some dinaries will do 1 rotation per year. So you start with planning, PDB, ES, and CS induction meeting. And throughout the year, you will do your workplace-based assessments. And let's say you do 1 teaching here, 1 audit here, and you start collecting your MSF. And now we are approaching the end of this rotation or mid-year point. So I'm gonna do end of rotation meeting with my ECS, because I'm gonna have a new CS starting from next rotation. And then with my ES, I will email my ES and request a mid-year review meeting. You start your next rotation, repeat, new CS induction meeting, workplace-based assessment, another teaching session because you need 2 teachings, more MSF feedback from your colleagues, and then towards the end of the year, you do your end of year meeting with your ES and CS. So this is basically how you plan for a 2 rotation year. 1 rotation year is pretty much similar. The only change is because your CS usually will stay the same because you are in the same rotation. So you might just want to do a mid-year CS meeting. Okay. These are some of, I hope these QR codes are still working, but if it's not, everything is Googleable. Basically, your RCR curriculum is on the RCR website. Your Kaizen portfolio, I think this is the link for the old Kaizen, but basically it is again on the RCR website. And if you want to improve your clinical knowledge for on-calls, I use this book. It's very useful, On-Call Radiology, about protocols and findings, or any other book you have. Basically, you don't need to use this specific book. And it's now time for questions. So there is a question from hand. Is there a specific number of scans to be reported per year, or is it different? Yes, that's a good question. So for it is it's different from deanery to deanery, not from trust to another. In our deanery, the only requirement that's there is 1,000 X-rays per year. Other than that, there is no specific number of CTs, MRs, or ultrasounds. But again, if you provide your logbook at the end of the year and you've done only 5 ultrasounds, for example, this is not gonna be in your favor. So if you have deficiencies in your other milestones, then you might get picked up on this one. But the short answer is usually the requirement is just for plain films. Any other questions?
I have another question.
Yeah.
Speaking of the number of the cases, why can a reporting session include too little amount of cases, and another reporting session include too much number of cases? I mean, the reporting logbook, isn't there a duty for each trainee to have a certain number or have a reporting session every day or according to a certain schedule? Why there can be a variation in the number of the reporting cases between one trainee and another?
It's highly variable because first of all, some of us might be doing on calls and others not doing on calls. So that's a huge difference. So in my on call session, in my on call, usually I do, for example, four nights in a row. Usually I report 100 to 120 CTs. If my colleague is not doing on calls, then they will have fewer numbers than me. Just that's as a start. Number two, and I probably did not mention this, but radiology departments in the UK are consultant-led, which means it is run fully by consultants. Most of the times, if you take the registrar out of the room, nothing will change in the day-to-day job because the consultants have to check basically everything. So if it is a very busy day, and for example, your colleagues are busy, your radiology registrars are busy with other things, they might just report 1, 2 CTs, and for example, they are studying for exam or something. And the consultants, to be honest, will not notice any difference because they have to check the scans anyway. So that's why there might be some discrepancies between radiology registrar reporting numbers. And again, the capacity of consultants to check scans are different. So for example, if you report with a consultant, they might tell you, can you please report 3 CTs because I don't have time to check more than 3 CTs. And also it is understandable because they have also busy schedules. Some other consultants might have extra time and might tell you, okay, can you report 6 CTs, 7 CTs, or report as many as you want. So at the end of the day, things can be really, really variable. Unless you have completed your FRCR exams, all of your reports are going to be checked by consultants.
So if I finished all the 3 parts of FRCR, some reports might not be checked by consultants?
If you wish to increase your numbers and you want to report as many scans as you want, you can report independently if you want. But if you are new to the UK, I don't advise you to not you specifically. I mean anyone new to the UK.
Yes.
I do not advise them to report independently in the beginning, even if you finished your FRCR exam, because you have a training scheme and the scheme is there to protect you. So it's nice to start under protection, basically.
Okay, I understand. Thank you. Thank you,
No
Dr.
problem. No problem. Any other questions?
Well, for now, thank you very much, Mohammed, for the talk. If there are any other questions, then obviously please feel free to pop them in the chat or say we'll still be around for at least a couple minutes. Do you have anything else that you wanted to say, Mohammed, to finish off?
Well, I just want to wish everyone good luck. And remember, you are in a training scheme, so you are well protected, well supported. The support is there from the beginning, so don't wait till it's too late. I know it's sometimes very difficult for us internationals to ask for support at the beginning because you don't want people to underestimate you. But it's better to ask for the support at the beginning and don't wait till it's too late. For me, when I started, I'll give you an example. When I started, I have already been working in the UK for 3 years and I have excellent on-call experience. Despite that, when I started, I asked them to shadow on-calls for 1 month, which was absolutely fine because I don't know anything about their system in the Northwest, and they have something called Radiology Hub where you cover 8 hospitals at the same time, and things were confusing basically to me. So the support is there. You just have to ask for it. If you feel that you have clinical needs that you need to improve, again, ask for it. And yeah, feel free to either chat, message us on the group, or I'm happy to take any. If you want to message me personally, I'm happy to support you as well. And yeah, good luck for your training.